Good afternoon once again. Good afternoon to everyone. It's a pleasure to welcome
Good
you.
afternoon.
Good afternoon, Ma. It's really a pleasure to welcome everyone to this important section on case management of infectious diseases. There are quite a lot of infectious diseases, so we're really going to narrow it down. Particularly, we're focusing on Lassa fever and cholera. My name is Amaka Obina. Let me introduce myself. Yeah, so these two diseases, they continue to challenge our health systems, especially in resource limited settings like ours. And that's why we're having section like this. Infectious disease outbreak, they do not just test our diagnostic capacity or treatment protocols. They kind of reveal the strengths and gaps in our preparedness and also our response coordination, our clinical competencies, and also how much we're able to engage our community. And so that's why, as IPC practitioners, it's really very important for us to continue to remind ourselves and keep abreast with improvements in IPC practices. So today we are privileged to hear from a distinguished speaker who is no other person than Professor Audu. Professor Audu Onyewuchi, I'm hoping he has joined. He brings a deep experience from frontline outbreak responses. As we listen today, I expect us to please take notes and also please put down your questions because he's really going to, take our questions as the section goes by. I would like to introduce him now. Professor Audu Onyewuchi is a distinguished professor of community health and a consultant of public health at Federal University of Health and Sciences in Otukpo and in Benue State University Teaching Hospital. As a pioneering fellow in Lassa fever case management, supported by Johnson University, the Nigerian Center of Disease Control (NCDC), and IROA Specialist Hospital, he has been instrumental in advancing public health initiatives. With over 20 years of experience, he focuses on capacity building, health system strengthening, and disease outbreak preparedness, particularly in sexual and reproductive health and gender-based violence. He has developed innovative curriculums, supervised medical students, and held leadership roles, including head of department and chairman of the Institutional Review Board. As an active member of international public health organizations such as Global Health Trials Network and the Nigerian Medical Association, he is dedicated to improving health outcomes in communities and leveraging his expertise in epidemiology, reproductive health, and youth development. Quite a robust portfolio. Please let's do well to welcome our speaker. So I'll use your favorite emoji to welcome our speaker for today. Prof, please confirm that you are online now. Let's see. Prof? Okay, let me see. Please just 1 minute. Okay, so while we're waiting for Prof to join, I want to confirm that Dr. Abimbola is here with us. Dr. Abimbola, you're on the section now. She's going.
Yes, good afternoon.
Good afternoon, Ma. Good to have you. I Yeah, it's good to have you here today. Okay, so I don't know if Prof is struggling with the network. I spoke with him just a few minutes ago. And then if we give him 1 more minute and he's not here, we might have to take the spotlight section. And then Prof, by the time he joins, then we continue. Please, Ma, would you want me to project from my end or would you want to project from your end?
Yes, you can.
Okay, I can.
Thank you.
All right, thank you, Ma. Okay, so while we're waiting for Prof, I'll quickly introduce Dr. Abimbola. She is in charge of the isolation center in Olabisi Onabanjo University Teaching Hospital, Shagamu, Ogun State. And also, she's also an IPC certified practitioner. So, Doctor is going to share with us some of the IPC improvements in her facility. Okay, so let's do well to welcome her with our best emoji on the chat box. Please, let's go ahead to welcome her. So, Doc, you have the floor while I quickly project your slide now. Thank you.
Good afternoon,
Good afternoon.
everyone, the coordinators of this program and colleagues that are online. I want to appreciate this opportunity to discuss with us on the IPC improvement in my facility, OOUTH Shagamu. We'll just wait for the slides while
Okay. So please,
before
everyone,
continuing.
are we able to see the slide?
Yeah, this thing.
Yes.
Okay, that's
You can see.
For the title,
okay. Go
the
ahead.
slide.
Go ahead, ma.
That's not my slide. That is not mine. The one I'm seeing online is not mine. Hello.
Hear you. Let me just give me a minute, ma, please.
Okay.
All right, thank you.
Hello, am I heard?
Hello. Oh, Prof, are you here now?
Online, yes.
Yes, I have.
Okay, we're actually waiting. We had wanted to. Okay, so let me just go ahead and share your slide. Dr. Abimbola, sorry, can we start with Prof first? Hope you don't.
Yes, ma'am. Yes, ma'am.
Okay, all right. Thank you. Let me just share his slide now. Okay, please, are you able to see the slide, everyone?
Yeah, it's visible right now.
Okay,
Yes.
all right, Prof, I have already introduced you. So we have the pleasure of having you. Please go ahead, sir. Thank you so much.
I can't see the slides either.
Are you able to see the slide?
No, I can't see it here.
The slide that is on is not prop slide. Please, we check.
Oh, it's
The one that is here is on IPC improvement at Obafemi Awolowo University.
Oh, I've taken that down. Okay, let me reshare. Let me share. Let me stop and share again, please. Let me reshare, please. Thank you. Okay.
Okay. Yes,
Are you able to
it's up
see?
now.
All right. Thank you so much,
Yes,
sir.
I can see it now.
Okay, sir. Thank you.
Okay. Good afternoon, everybody.
Good afternoon, sir.
Are you hearing me?
Yes, we're able to hear you,
Good
sir.
afternoon,
Yes, we
sir.
can hear you.
Okay,
Good
I want to
afternoon,
help
sir.
you. Since we are sharing it from your end there, you will help me obey little commands to be moving the slides as fast as possible. And I want to appreciate everybody, but most especially the organizers of the ECHO project, and in particular, Nigerian Society for Infectious Control, and also the Infection Control African Network. My name is Audu Onyemocho. I work with the Institute of Global Health, Federal University of Health and Protocol, and I also work with the Benue State University Teaching Hospital as a consultant community health physician. Next slide. So my assignment today is to briefly talk about the case management of infectious disease, after which we look at the lessons learned from Lassa fever and cholera. So the content of this discussion will go in this format. First of all, we briefly look at the historic perspective of infectious disease, under which we look at the process, then the case management in general for all the infectious disease, like a template. Then we talk about the Lassa fever case in Nigeria, and then briefly management of cholera, and then the lessons learned from these two, after which you have questions and answers. Next slide. By background now. Now, let's look at what is infectious disease. Infectious diseases are disorders that are caused by organisms. These organisms are microscopic in nature, and we don't see them with the naked eyes. But by classification, they can either be a bacteria, a virus, a fungi, or a parasite. The common thing that is, one thing that is common to all these organisms is that they can be spread through contact with contaminated surfaces, the food that we take, the water we drink, or through body fluids. And in some instances, they don't transmit from human to humans or through the surfaces. They can also be transmitted by having contact with animals. In that case, we call them zoonotic in nature. The symptoms of all this is dependent on the pathogens, but they have something in common, like the fever, the chills, fatigue, and also muscle pain. Why did they have fever? It has been documented that most of these microorganisms, when an individual gets contracted, there will be release of interleukins, which brings about fever. So fever is common to all of them. Next slide. So in the memory lane, we look at some of the examples of the infectious diseases that we have had in the past. Between 541 to 542 AD, there was a plague of the Justinian. In this case, Yersinia pestis was the cause of that. And it leads to a lot of epidemics that killed a lot of people. After the down of that empire, the disease went off. Between 1346 to 1353, there was another recorded epidemic also caused by Yersinia pestis. It is also a bacteria, and it was called bubonic plague. This lasted for a very long time, and a lot of people were killed. In 1494, syphilis again came on board as an epidemic, also an infectious disease. This was caused by Treponema pallidum, and a lot of people were killed, but later solutions were found for it. In 15,000 AD, tuberculosis also came as another epidemic until about 1882, when the organism that causes as Mycobacterium tuberculosis was discovered by Robert Koch. And you may recall that it is still in existence today. Then in 1520, there was smallpox. This smallpox was caused by bacterium called Variola majors. But however, it was eradicated in 1977. In 1793, there was a yellow fever epidemic again that rampaged the whole world, and this was caused by an arbovirus that was transmitted by Aedes and Haemophilus mosquito. And after this, in 1817 and 1964, there were about 7 epidemics or episodes of cholera pandemic. And these have been in existence. And after that, we have had several epidemics. Even in Nigeria currently, I think about 2 months ago, we had epidemics in other parts of the country. In 1918, there was a flu epidemic that was caused by influenza virus. In 1969, we had the case of Lassa fever, which formed one of the topics that we're going to discuss today. In the next few slides, we'll just discuss briefly about Lassa fever and what it has caused. In 1976, there was Ebola. In 1981, there was an HIV epidemic, which is still in existence today, and it is now been documented that this was caused by human immunodeficiency virus. In 2003, there was a SARS and MERS epidemics. In 2009, we had the swine flu. In 2014, there was another epidemic. 2016 and 2019, which is the recent one that we have, COVID-19, which means that infectious diseases have been living with us right from time immemorial till now, and we have sporadic cases of this epidemic. Once it comes, some have been eradicated, some are coming as emerging, and some are coming as re-emerging. Next slide. What is the common thing that is, what is that thing that is common to all? All these epidemics are caused by a particular agent, which may be bacteria, it may be a virus, it may be parasite, and so on and so forth. And it affects hosts. These hosts are a group of individuals. And I would like to say at this point that everybody is a susceptible host. And there's also a relationship between the host, the agent, and the environment where the host and the agent find themselves. This environment provides an ecological niche where the agent cannot thrive, and now it can affect the host. So when there's an imbalance in between the agent, the host, and the environment, it leads to an epidemic of a particular organism. And this, in epidemiology, we call it the epidemiological triad. Next slide. Now, what is the process? When an infectious organism or these microorganisms enters an individual, there's what we call the incubation period. From the time when the person gets contracted of the agent or the illness, so the time that the person now manifests with specific symptoms of the illness, we call it incubation. And after incubation, there's what we call the prodromal period, which is the time period between the incubation period and when the specific symptoms of the illness may now develop. After that period, when the specific symptoms now develop, the individual, depending on the immune system, may be able to fight against this organism, and when they may now get recover. And such individuals are said to be asymptomatic. But some few individuals may present with the symptoms of the illness, and if nothing happens at all, it's either they die of the sickness or they recover and they go to the convalescent state of the illness. Next slide. So what is the hallmark now? From that triad, it means that everybody is susceptible. And once you are susceptible, it means you can get exposed. Once you are exposed, it's either you get infected, and once you get infected, then you can either recover, or if you don't recover and you manifest with the symptoms of the illness, which can be mild or moderate or severe, then it means you have to be treated. So what we need to understand at this point is that everybody is susceptible to the illness. Early diagnosis and treatment is very key. And once you are treated, it's either you get cured or you get disability, and after that you can recover. So the whole essence of the management of an infectious disease or an epidemic is geared towards the fact that everybody is susceptible, you can get exposed, you can get infected, and you can also get recovered. Next slide. So now, if that should be the case, what is now the case management? The case management, irrespective of the type of the illness, depends on what a thorough history taking has to be done. After that history, we talk about the contact, about you go through the process, the incubation period, the prodromal phase, the illness phase, and the symptoms that may be specific to that individual or to that agent, and whether you have any contact with the person. Based on the knowledge of the incubation period, you'll be able to ask, in so number of days or hours, have you get exposed to somebody who has the illness or not? After that, a thorough clinical assessment be done, have general assessment, then specific organ assessment. And in few cases, when a suggested diagnosis or a working diagnosis is made, they will now go for a laboratory investigation. And if that is being done, then the person or the individual who is now confirmed or diagnosed for a particular infectious disease has to be treated. And this treatment can either be via through pharmaceutical or non-pharmaceutical means. Now, at this point, it's also worth to know that IPC, which is an evidence-based, it cut across all the stages of the management of every infectious disease. While you are doing history taking, IPC has to be in place. During clinical assessment, IPC has to be in place. During laboratory diagnosis, IPC has to be in place. And even when the person is being treated, either through the pharmaceutical or non-pharmaceutical means, IPC has to be in place. Now, I'm not going to go into details of all the processes of the IPC, but most of the time we use what we call the multimodal approach. Next slide. Now, what we do in the case management. Now we have talked about a summary. You take history, you take clinical assessment, you take laboratory diagnosis, and then you treat. For those that have been confirmed, this is the third stage, either through any means of this diagnosis, what you need to do is that you do the clinical assessment again to classify the severity of the illness, and you look at the danger signs, whether the person can recover or the person have a life-threatening situations. The management is not the same, and it is dependent on that stage. For individuals that have mild symptoms of the illness, and there's no risk that is attached to maybe the individual transmitting the illness to others, they can be managed at home under close monitoring. Then, if you talk about the clinical management, is also dependent on whether the illness is mild or it is in a severe form. If it is mild, we treat symptomatically. If it is severe, then we have to look at the component of that severity, the organs that is involved, and whether there's any comorbidity or not. Next slide. Now, with this background, let's look at what we are here for. We're talking about Lassa fever and also the cholera as an example. Now, Lassa fever has been there since 1959, which means that this is about 56 years ago. And it started with a story at Lauren Wine. Lauren Wine is an American missionary who worked in a village called Lassa in Borno State. Now she presented with symptoms of fever, backache, sore throat. Subsequently after that, she developed, hemorrhages from some part of the body. The urine now reduced in volume. And as usual, she was given chloroquine, which was a conventional drug that was used for cases of fever. There was no, she didn't recover. She was also given penicillin. And after that, because there was no recovery, she was flown to Evangel Hospital, which is now the Bingham Memorial Hospital in Jos. Next slide. After that, while she was in Bingham or the Evangel Hospital, Charles Shaw was trying to attend to her. And she gave her oral toileting using her finger that she was wrapped with gauze. But before she did that exercise, while she was watering her flower in the morning, she got pricked with a flower and she never knew. And because of that, she got contracted of the illness. And the same symptom that Lauren Wine had then. Dr. Janet Troop, a female doctor, trying to assist Charles Shaw. And at the end of the day, she also got contracted of the illness 11 days after Charles Shaw had the symptoms of the illness. And Charles Shaw also died. Next slide. So that now, because of the worry that Janet Troop had, she now had to report herself and try to do an autopsy on the body of Charles Shaw. And she was accompanied by Penny Pilio. Later, she also developed the symptoms. Penny Pilio did not die. And because she didn't die, her blood now was taken. Next slide. to what we call the present Yale Arbovirus Research Laboratory. And that was when the group of the scientists that was led by Judy Castle discovered that all these illnesses that have started from the chain of Larynx to Charles Shaw, that it was caused by a particular virus which they never knew the name. And for that, they now had to give it a name as Lassa fever, using the name of the village where the first illness case was discovered. Next slide. Now, it is not a new history or a new story any longer. It is now endemic in almost all the states in Nigeria. And it has also extended to other parts of the West African countries. Like we have it in Benin, in Cote d'Ivoire, in Ghana, in Guinea, and Liberia. Mali also has several cases, and Sierra Leone and Togo. So it has now become an endemic disease in most of the ECOWAS countries. Next slide. Now, I will not go into detail of the distribution or the frequency of the cases, but there is virtually no state in Nigeria that doesn't have Lassa fever any longer. Now, how is it transmitted? The transmission of Lassa fever, mainly, it was initially a zoonotic infection. You have the Mastomys natalensis. When they now urinate on the food, it contaminates the food, either with the feces of the urine. And susceptible individuals that now consume any of these contaminated products now get the disease. From the zoonotic component, there's a spillover to human component. Now, the human transmission is mainly through either direct contact or through droplets. Now, if you look at, next slide, please. For the few individuals that may have the illness, the incubation period is between 2 to 21 days. 80% of cases are asymptomatic, and it's only 20% that present with the symptoms of the illness. And what are those symptoms? The cardinal point here is fever with temperature of 38 degrees Celsius or above. There's malaise, there's headache, sore throat, cough. There's also nausea, there's vomiting, there's diarrhea, there's myalgia, there's chest pain, there's hearing loss, and either of the above. And these symptoms is also dependent on the stage that the individual presents with. For those children that present with the mild symptoms of the illness, all the symptoms will not be there, but 80% of the cases, there is fever. And when you take the temperature, it's 38 degrees Celsius on above. There could also be a history of contact with excreta or the urine of rodents that we find in our environment. And there could also be history of contact with a probable or a confirmed case within the 21 days of the onset of the symptom. Any of this, the NCDC classification call it a suspected case. Next slide. You can also have confirmed case. The confirmation of this illness, the gold standard is the real-time polymerase chain reaction. But in addition to that, the IgG-IgM can also be positive for an individual that has the illness. And why is it so? In the first few days of contracting the illness, the IgG-IgM comes up, they keep increasing, then gradually it comes down. That is when the virus, the viral load also increases. So what the PCR picks is the virus, the viral load. So, and there could also be virus isolation. When this test is being done on a suspected individual, and it is positive, it means that the person is being confirmed. But in addition to confirmed cases, you can also have a probable case where you have a suspected case, either the person present with the symptoms of the illness or there's history of contact within the 21 days of the incubation period for a confirmed case. But in this situation, once the test has not been done, the laboratory confirmation has not been done, it's a probable case. Why do we need to learn about all these things? It will guide us on what to do and what we have been doing in most of the isolation centers. Next slide. Next slide. So this slide just gives a summary of the symptoms that the individual may present with. At the initial phase, I've already stated that we have fever, headache, malaise, body aches and pain. There could also be vomiting, as the case may be. There could be sore throat. Then we could also have no specific symptoms, which is dependent on the severity of the illness. Some people can have conjunctival hemorrhages. They can also have hearing, impairment, even though it is not common to have that at the beginning of the onset of the illness. And there could be features of complication. But most of the cases that we have, that we lose, the case fatality rate that is very high, most of the time is attributed to acute renal injury, where you have oliguria. They can also have seizure and facial edema. They can also have confusion and seizures, and some other complications that may come up with respiratory complications. You have dyspnea, tachypnea, and reduced SpO2. There could be simulated intravascular coagulation because of the hemorrhages, and that can also lead to anemia that may warrant blood transfusion. There could be encephalopathy. They can also go into shock because of the low blood pressure that they could be attributed to because of the anemia or the vomiting that the person may have. They can also be liver impairment. So the presentation is dependent on the stage of the illness. But however, my cases present just as any other fever you may have. Next slide. Next slide. So now, for those that are confirmed, what do we do about them? Treatment of confirmed Lassa cases is done in the isolation center. And most states now have isolation center. For Benue State, where I work, the isolation center that was being upgraded during the COVID time is in the Benue State University Teaching Hospital. And all the peripheral hospitals, either public or private, have been encouraged to have to have a holding area. Once there's a suspected case, they hold the patient there, take the sample through the DSNO. Once it's confirmed, they now transfer them to the isolation center for treatment. Next slide. So what are those things that you do in the treatment modality? First of all, you have to do screening and triaging. In the screening, you look at it whether it is suspected or it is a confirmed case. For suspected case, I've already defined by NCDC criteria. I want to talk about the confirmed case, and the gold standard is the real-time PCR, and where you can also have the IgG-IgM. But IgG-IgM is more of a seroprevalence of the illness. But however, you can also have viral isolation. Once it is positive or it is being suspected, you now put them in isolation. And from the isolation, you do triaging. Why do you have to do triaging? Triaging, it means you look for the warning sign, and then you go for confirmation. And then you classify the patient, whether they are mild or whether they have the severe case. For those that have severe cases that need extensive management, they may have to be kept in the intensive care unit. So, and the good news here is that most of the isolation centers have where you can treat mild cases, and you would also have an intensive care unit where you can also treat severe cases. Next slide. So what do you need to do? Whether it is mild or it is severe, clinical assessment is key. And that you have to do among recognition of the danger signs. Then you now isolate the patient and give them the treatment. For severe cases, you treat, for mild cases, treatment is symptomatically done. While for severe cases, you have to take the treatment with drugs, with ribavirin, and where they need support, depending on the organ that is involved, then you now do that appropriately. Next slide. What you do is that you introduce them to intensive unit as fast as possible. Where there's no specific symptoms of the illness, ribavirin is being given. And for places where there's high index of suspicion based on the presentation of the illness of the case, you have given an anti-malaria for more than 2 weeks, and there's no the patient is still presenting with high-grade fever. What we do, we commence ribavirin immediately. And why do you have to do that? Because by the time you wait, most of the time, when you do the diagnosis is with molecular lab. And it is not all the states that have molecular lab. Initially, we're sending all our samples to the National Reference Laboratory, and the turnover time is between 3 to 4 or 5 days, as the case may be. When there are other bottlenecks, it may extend more than that. So you don't have to wait for such things to be done. Once the test comes out negative, now you reevaluate the patient and see whether you can transfer them to the general ward or not. If it is positive, then you continue with the treatment. Next slide. Next slide. So intensive care, it is done for all patients that needs that. And how do you get that? Is by monitoring the patient, and you look at the stage of the patient, you look at the viral load, and you look at the clinical presentation of the patient that the patient may come to the hospital with. On a daily basis, you have to do that. And once the patient needs a supportive care, you now support them with either with fluid, electrolyte, where there's a renal impairment. In some cases, you do dialysis, and you also do other supportive care. Next slide. So the hallmark of the management of Lassa fever, aside being either mild or severe, daily monitoring is called. And why do you have to monitor? Because the person can tilt from one situation to the other. A patient may come to the hospital in mild condition, and they want to tilt to a severe condition based on the organ involvement. Next slide. The vital signs that you do to monitor the individual so that you can place them appropriately is what you do on a 4-hourly basis. You check the vital signs. Then you can also do the fluid status of the patient. On admission, each patient that comes to the hospital, you observe them, you check their hydration status. Where they are dehydrated, you have to give them fluid replacements. You also do physical examination. Then you check the blood pressure on admission, and you check it frequently. You need to do dipstick on admission. And what you need to do there, at times when you don't have the PCR, just by looking at the urine alone, if it is Coca-Cola color urine, it now becomes suspicious. You also do blood tests on admission, and you can monitor it on a regular basis. Then we also do the viral load on admission, then 5 to 6, 7 days while the patient is still on admission, because most of the time, if there's no complication, on the 10th day, the patient is being discharged. Next slide. Now, the vital signs that you also need to do, you need to do the SpO2. And what do you need to check there? If it is less than 92%, it means the respiratory organ is being involved. And there may be situations where you have to give oxygen. And this can be evidenced by also tachypnea and hemodynamic instability. Now, time will not permit us to go into details of all this. But what we need to know at this point is that in doing your vital signs, it is not just one organ that you check. It is a multi-organ assessment. And you can also check the fluid. Where there's oliguria, it means the urine output is reducing. And for adults, if it is less than 0.5 mils per kilogram per hour, it is mean that the kidney is gradually being affected. And what do you need to do? You need to invite the specialist, and that is the nephrologist, to come and have a look at the patient while you do your investigation and continue with the management. Next slide. You also check the central nervous system, and you look at where patients vomit. You have to check if the patient is going into hypovolemic shock. Then you replace with fluid. If the patient is bleeding and there's evidence of anemia, then you may have to transfuse, as the case may be. Next slide. Capillary blood glucose is also being tested, and you also do blood tests. Next slide. The biochemistry that is needed: sodium, potassium, bicarbonate, creatinine, and urea, AST for the liver function, and ALT, magnesium, glucose. All these have to be tested. We're not going to go into details, but where there's a deranged value, it means I have to look for the specialist. That is to say that the management and the monitoring of Lassa fever patient, just like any other infectious disease, it is a multidisciplinary approach. Next slide. So where there is need for fluid support, you have to take it, have to give to the patient. If there's cardiovascular support that is needed, you bring cardiologists. If there's hematology support, you bring hematologists. If there's renal support that is needed, you bring the nephrologist. If there's respiratory support, so you bring all these specialists so that you can manage the patient. And nutritionists are also important. There are also some special cases, which I'm not going to discuss in detail here, but there are special cases where you have, aside this central management, they could have a pediatric patient that have been contracted of this illness. The management goes like that of a pediatrics. Pregnant women can also get contracted, and when they are pregnant, now intrauterine fetal death can also occur. The gynecologist has to also take care of such kind of management in a special way. Time does not permit us to go into detail of all these subspecialties. But what we need to know here is that once there's any subspecialty that is needed, such specialty has to be trained and they have to come on board. Next slide. Conventionally, we give ribavirin, and what we do is the McCokin regimen, and this we have a loading dose of 33 milligram per kilogram to the maximum of 2.6 grams as a starting dose, because most of the patients stay between 1 to 10 days of admission. On the day 1 to day 4, you reduce the first dosage not half by giving 16 milligram per kilogram body weight to maximum of 1.2 grams, and you give it 6 hourly for day 1 to day 4. From day 5 to day 10, you give 8 milligram per kilogram body weight to the maximum of 0.64 grams, and you give it 8 hourly. Next slide. Now, this is a borrow slide from the IRWA, and I want to acknowledge them at this point, that what the IRWA did, and we have now called it the IRWA regimen of the ribavirin. The loading dose is 100 milligram per kilogram body weight to maximum of 7 grams, and you give it in 2 divided doses. The 2/3 of that divided doses is given at the start. Then 8 hours later, another 1/3 will be given to the patient. From day 2 to day 7, now 25 milligram per kilogram body weight is given as a single dose on daily basis. Then from day 8 to day 10, 12.5 milligram per kilogram body weight is given on daily basis, but that is day 2 to day 8 to day 10. Now, it will interest us to know that where I work in the Benue State University Hospital, while using the IRWA regimen, I will discover that most of the patients that come around at the recover, except those that come very late with severe symptoms of the illness, and maybe they must have passed from one place to the other, seeking for other means of treatment. When they come very late, they will have the mortality. But for those that come early, I will start the IRWA regimen, and on a good time, they get recover without complication and they are discharged home. Next slide. Now, if you are giving ribavirin or you are treating Lassa fever, you may recall I told you from the beginning that at every stage, either from the suspected case, from the time you have your referral, from the time you have your diagnosis in the laboratory, from the time you have the treatment, IPC is very key. And we're not going to discuss that in detail. However, you avoid non-steroidal anti-inflammatory drugs because of the bleeding tendency that the patient may have. You avoid intramuscular injections. Most of the time, any drug you have to give, the ribavirin is given IV. Now, the use of cotton wool to clean the mouth of the patient, if you may recall the story of Larry Wine and Charles Shaw, that you have to avoid that. Any skin ulcers must be cleaned and dressed gently because they may bleed. You avoid a nasogastric tube, urinary catheters. We don't insert except when it is highly needed. And you don't move old blood clots from the previous bleeding sites. Never recap needles. And then for pregnant women, genital vaginal examination must be done only when it is needed. And you have to be on full PPE. Now, even though the PPE, if you look at the hierarchy of the management of infectious disease in IPC, it is lowest and in terms of efficiency. But with regard to Lassa fever, you have to be on full PPE where you're going to have a maximal contact with the patient. Next slide. Now, I'm not going to go into detail of all this. This is the assessment that you do. This is a checklist. Every treatment center need to have this checklist. If it is treated
Okay.
anywhere,
Know
know that yes, you have to see the thing. Next slide. Next slide. Now, let's go to cholera now. Now, how do we treat cholera? Cholera, we have had several epidemics in the past, and it is still happening around us. It is an acute diarrhea illness that is caused by infection of the intestine. And hello, are you hearing me?
Yes, I can hear you.
Okay, next slide, please. Next slide.
Okay, I think it's network. Let me try and stop it.
No problem. Let me continue.
Okay.
Now, cholera is an acute diarrhea disease. It is caused, there's an infection of the intestine with a bacteria called the Vibrio cholerae. And this, it is spread by ingestion of contaminated food or water. There can also be direct contact. The incubation period, unlike that of Lassa, which is about 1 to 21 days, is happening within hours to days. Most of the time, between few hours or 5 days, and the average incubation period is about 1 to 2 days. The key symptoms is that of diarrhea. The individual may also have vomiting. There's fatigue. There's muscular cramps because of the fluid that is lost from the body. There could be weakness and also extreme thirst. So rarely, they also present with shock and seizures, and if it is on a severe case. So what you need to do is to rehydrate the patient and by use of IV fluids. Antibiotics can also be used. Now, in the management circle, now what you need to do, first of all, you have to assess the hydration status of the patient once they come in there. And if they are dehydrated, you need to give fluids. And after that, the rehydration assessment has to be continued. Once you continue with it and you are not satisfied, then you have to rehydrate on the patient is fully okay. And you also maintain this by giving this different types of fluids. There's also room for antibiotics. If the dehydration is severe, prophylactically we also give antibiotics. So in this case now, the case management of diarrhea disease, just like any other infection, first of all, you have to take the patient to the isolation center. You manage them accordingly. But unlike Lassa fever, that is highly contagious, that you need a typical isolation center, cholera is not like that. So, and the hallmark of the treatment of cholera is fluid replacement. Once you can give that fluid, then the patient can now come back to life. Next slide. So in summary, what have we been able to discuss? Now, for every infectious disease, we need to have a high index of suspicion. And once they have been admitted, effective monitoring is key because there's an evolution. The patient may present with mild symptoms of the illness and they can tilt to the severe form of the illness. And you have to have an early warning score system. For the Lassa fever, the last slide I gave there was a checklist, which has to be a guide. Investigations have to be done serially because of the fluid that is being lost from the body and also electrolytes. Biochemical and hematologic monitoring is key to most of the infectious disease epidemics. And once it started, there's tendency that it can extend to every organ in the body, so it can become a multi-systemic involvement. And for that, every organ has to be assessed. And when there's need for supportive management, depending on the presentation, which will either get from the physical examination of the patient or from the biochemical parameters, then you have to monitor and manage the patient accordingly. Next slide. What are the lessons that we have learned so far? Now, when this question came, I tried to ask myself, what are the lessons? Yes. All we need to know that infectious disease has been existing for a very long time. It is as old as the creation of the universe. Some have gone, some have been reduced so that they are no more of a public health importance. But even after they have been reduced to the level that they are no more of public health importance, they can also re-emerge. So there's tendency for re-emerging and also emergence of new form of diseases. And most of these are linked to limited access to safe water. They are also linked to basic sanitation facilities and poor hygiene practices. And that is why IPC is very key. The risk of an infectious disease outbreak is highest when there's poverty, when there's war, and when there's natural disasters that affect the people. Which means that from what we are facing in our country today, there's tendency that even the ones that have already are no more of public health importance, they can re-emerge, and a new one can also emerge. So we have to be on the watch out. And there are treatments that are available, and most of these treatments are very effective. Looking at cholera and Lassa fever, for example, the treatments are very effective. The use of ribavirin has been very effective, and then the rehydration of individuals that have cholera has also been very effective, and even the prophylactic use of antibiotics. Late referrals and diagnosis and treatment are the major challenges to the case management of all infectious diseases. Most of the time, they are found in the places that have poor environmental hygiene, poor water, and poor sanitary conditions. And now, what do we do? Once the case come up there are limited health facilities that can also diagnose these illnesses. And what they come, what to do? The referral system can also be a problem. And from the referral leakages, when they go to hospitals or health facilities, where a definitive diagnosis has to be made, there are other bottleneck issues. So referral cases to diagnosis, to treatment, and from the course of this lecture, we all believe that everybody is susceptible to the illness, but the immune system of individuals varies. But once you are exposed and have the illness, how do you get the diagnosis being done? Lassa fever, yes, molecular lab is now available, but what about the light that you need? This test has to be run for about 7 hours at a stretch. So you have the money to buy the fuel or the diesel when NEPA light is not there. So these are the challenges that we have been facing in the recent time. Then what about the case fatality rate? The case fatality rate of Lassa fever is very high. Even though it is 20% that are symptomatic, of those 20%, of those that come to the hospital very late, they also get contracted of the illness. Another case that is also an issue now is the healthcare acquired infection that it has also been on the increase. And then mycobacteria, resistant antibiotics. So what do? IPC is key at that point. So in summary, what do we need to do? Because these things have been living with us, these illnesses have been living in us, and there's tendency that they can come back again, and everybody is susceptible, and we need to have a good early referral system, we have a good diagnostic system, and also need to have a good treatment modality. We need to have a high index of suspicion. Early referrals is very key. Good, the diagnostic kits are also paramount importance. And this is where I want to encourage everybody. You also have to go into research so that we can get new diagnostic kits that are very effective for early diagnosis and treatment. And then treatment are also the hallmark of infectious disease. At this point, what is the key messages now? Next slide. The evolution of infectious disease that we have learned shows that over the years, over the decades, they have been coming and they have been going. And then the management of infectious disease is key. But this management does not just stop at you giving the treatment. You need to have a high index of suspicion. You need to refer where you cannot manage, and you need early diagnosis and early treatment. If that is not done, then nothing is being done. And if we follow all this and we cap it up with adherence to IPC practices, then we are going to achieve either eradication as we have for the smallpox in 1977 and for other cases. And then the ones that are going to come, we cannot prevent them. I want to acknowledge NCDC because some of the slides I have here are from them. I also acknowledge Irua Specialist Hospital. I also acknowledge Georgetown University, who trained me as a fellow, because some of the slides I also adopted from them. I also acknowledge the WHO, and I also acknowledge Wahoo for some of the slides that I also take from them. And finally, I want to thank my audience for giving me this time, and then the NIC for the privilege to have shared these few points. Thank you for listening, and God bless everyone. Thank you.
Thank you so much, Prof. Thank you. Thank you. Please let's appreciate Prof with our emojis on the chat box. Prof, thank you so much for such an insightful and experience-rich discussion. We really, really appreciate you sharing your expertise with us. Please let's appreciate Prof. Prof, you've really helped us, to see that case management isn't just about administering treatment. It's also important that there is early diagnosis and prompt treatment. It really plays a critical role in the prevention of infections. Thank you so much, Prof. We really appreciate. Please, I would love us to please put our questions in the chat box. Please, Prof, please don't go away. We quickly have the spotlight section, and then we come back to the questions and contributions. Please, if you have your questions, put them in the chat box. I'll go through there and try to retrieve them. So let's quickly, Prof, thank you so much. Thank you so much. We can't thank you enough. So let me quickly share the slide for the second speaker, Dr. Abimbola. Okay, please confirm that you're able to see the slide.
Yes, ma.
Oh, thank you.
Yes,
Thank you, ma. Please, ma, you have the floor
Yes,
now. Thank you so much.
okay. Thank you very much, Prof, for the lucid Dr. Abimbola. I'll be sharing our experience on IPC in Olabisi Onabanjo University Teaching Hospital in Shagamu. Olabisi Onabanjo University Teaching Hospital is a public teaching hospital located in Shagamu, Ogun State, Nigeria. Was established in January 1986. It serves as a primary clinical training facility for medical students from Olabisi Onabanjo University, Agoiwoye, formerly known as Ogun State University Teaching Hospital. OUTH is affiliated with OOU and plays a vital role in providing healthcare services to Ogun State and Nigeria at large. Ogun State is the gateway city. So many states pass through us to get to Lagos for the big that country. So the teaching hospital is well situated. OUTH has undergone significant growth since inception. Initially, the hospital operated about 100 beds, but over time, this capacity extended to over 300 beds to accommodate increasing patient needs. The hospital bed distribution across the departments include medicine, 2 wards with 20 beds each, male and female, inpatient care, pediatrics,
Hello, Ma, you still there? I think it's network. Dr. Abimbola, please, are you still on the call?
Yes, ma. Yes, ma.
Right, go ahead, Ma. Thank you.
Okay, sorry, a call came in.
Okay.
The IPC unit of OUTH, we have two doctors, a microbiologist, infectious disease physician. We have 4 nurses, the 2 trained in infection control and 2 trained in public health. Then we have 4 trained health attendants. The role of the infection control team in the hospital is to prevent and manage. This slide is not moving, ma'am. To manage healthcare-associated infections, prevent and manage, to handle the antimicrobial resistance, and also they are involved in outbreak control. They have daily activities that include monitoring of the cleaning schedules in the wards and the hospital environment, waste disposal, hand hygiene material, and provision, as well as monitoring of the practices, healthcare-associated infection surveillance, record and management of occupational hazards like needle prick injury, post-exposure prophylaxis for HIV, hepatitis, then communicating and reporting to the management. Their line of communication include distribution of IEC materials and posters within the hospital wards and the environment, the daily briefings at meetings to give reports. Then written reports are also presented during grand rounds and at the infection control committee meetings. They paste important messages on notice boards. They post messages and jingles on unit and departmental WhatsApp platform. Concerning the infection control plan for the hospital, there is one that has been adopted from the NCDC, and the purpose of the policy written was to establish standards and guidelines that prevent healthcare-associated infection, ensuring patient and staff safety, and complying with national and international regulations. So the policy applies to the healthcare workers and the students that are being trained, as well as the people, staff that work within the hospital premises. The key components of the policy include the person leading the team, standard precaution, transmitted-based precaution, surveillance, antimicrobial stewardship, environmental hygiene, waste management, as well as occupational health, outbreak preparedness and response, as well as education and training. Also monitoring and evaluation, regular audits, compliance checks, reporting of key performances, as well as continuously monitoring quality improvement initiatives. The policy is meant to be reviewed annually, and it was approved and signed by the CMD. So talking about the policies, we also have the Infection Control Committee. They have meetings, the Infection Control Committee includes the infection control team, then the heads of the various units in the hospital. We have HODs of different departments as part of the Infection Control Committee. We have management representatives, and the meetings are supposed to be held quarterly for the Infection Control Committee to also report back to was slated for the month of June 2025, which is next month. In the meeting, the last meeting held, and the previous meetings we've been having. The highlights of the meeting include surveillance data review. What are the documentations of the disease conditions that we have that's been increasing or that we label as outbreaks, the reports about them, the lessons learned, like Prof gave us lessons learned from cholera and Lassa fever outbreaks. Audit and compliance finding, like the hand hygiene, how people have been compliant with it. Then we also discussed about the policy and guidelines, talking about how they can be updated. Then we'll talk about trainings. We review the training of the staff. They talk about resources and supplies, if there have been issues or if they have been adequate. We also talk about occupational health updates. Have we had increasing or reducing incidences of needle prick injury, post-exposure prophylaxis for the affected individual? We'll talk about the vaccine availability for the staff. And we'll also talk about what next steps to take. And we'll give individual members of the unit, of the group, assignments to do. Then we also talk about engaging the leadership and giving a feedback to them as well. Next slide, ma'am. Concerning the IPC policy and procedures, like I said, we have an adopted one from NCDC. We have soft copies in the critical care areas of the hospital. The isolation centers, they have their soft copy, our ICU theater, and the CSU, the Central Sterilization Unit. The surveillance, concerning surveillance, we have a trained public health nurse that is in charge of the surveillance team. They use SOMAS for their data collection, and the surveillance we perform in the hospital varies depending on the situation and the time. We do active surveillance, passive surveillance, targeted surveillance, point prevalence surveillance. We do antimicrobial resistance surveillance, environmental surveillance, outbreak of investigation surveillance, as well as occupational health surveillance. Because of time, I might not be able to go into details to explain them one after the other. In the last 1 year, we have had outbreaks. When we talk about outbreaks, it talks about you are having more than the regular number of cases within a period of time. Last year, June, July, we had outbreak of cholera. We had so many cases coming from the community into the hospital, more than what we normally have. At the isolation center, we're able to manage 14 cases, no deaths. They went back home safe and sound. We had 2 cases of Mpox, 3 cases of chickenpox, only 1 case of Lassa fever in the last 1 year. Unfortunately, the patient died even before the results of the Lassa fever results came out. We had about 8 cases of yellow fever and a case of diphtheria, which also went back home safe and sound. They were managed, these cases were managed in the isolation center. When there is an outbreak, how do we handle it? What do we do? Number one, we want to identify and confirm that indeed there is an outbreak. When we confirm, we notify the stakeholders, the leaders, management team, the disease notification officers in the states, and the staff within the hospital. We also we have a rapid response team. Join us when there are outbreaks. We call them the rapid response team. We convene a meeting and we conduct investigation. We discuss how we're going to outline our plans, and there's immediate implementation of control measures. We give regular updates to the staff and the patients we monitor and evaluate, we document and we report our findings. Thereafter, we have the post-outbreak review, and we take steps to reinforce prevention. The slide is lagging behind. So that is what we do when we handle how we handle our outbreaks. The training, concerning training, we do trainings once every 6 months, especially and at entry points of new staff. What we train them, or we train the doctors, the nurses, as well as the health attendants. We don't have regular 6-monthly training of staff that have been in the hospital for long based on reduced resources. What we do regularly that we have not been missing is the training of the new incoming staff, doctors, nurses. At entry point to the hospital, we give all of them training. What do we train them on? We discuss standard precaution, transmission-based precautions with them, and the hygiene protocol, because we know that it has an important role in reducing the infection rates and the risk and outcome of our patient care in the hospital. We talk to them about sterilization and disinfection, waste management, sharp safety, outbreak investigation and response, antimicrobial stewardship, data management, and surveillance. Like I said, categories of staff that we train: the healthcare workers in the institution, but most especially even the IPC team. We go for regular updates trainings, and the clinical staff, the environmental staff, the waste handlers that are in the hospital, the engineering and maintenance staff, also our students and interns in the hospital are also among the people that are trained. For OUTH, our strengths include availability of an isolation center where we manage our infectious disease cases. Like Prof said earlier, when we have these infectious disease cases as outbreaks, what we want to do is, and what we encourage every facility to do, is to have an holding area while samples are collected and the patient continue to be managed there until they are confirmed and they are referred to isolation centers. But in our teaching hospital, we have a place where we can even put the suspected cases for monitoring and management while we await the results. And we have another section where we manage confirmed cases. Then also we have trained specialists for pediatrics as well as adult infectious diseases. The cases of the diphtheria we had last year was 1, 2 this year, and there are pediatric cases. The infectious disease consultant in pediatrics was available to work with the isolation center staff. Then the multidisciplinary team approach. Like I said, we have a diverse response, rapid response team. Healthcare workers, not just doctors and nurses, that are ready to join us in case of any outbreak. We have clinicians, microbiologists, pharmacists, nurses, environmental officers, and management staff, so that we can have a comprehensive expertise in the management of these infectious diseases. Also, we have the infection control team and the surveillance team that are active and available all of the time. Also, we have the adequate supply of PPE. We have a store where we have different materials: the gown, the boots, the gloves, the N95, the surgical mask, and so on, that we need when we have patients to care for as infectious disease cases. Those are the strengths that we have. However, there's no way we walk and our hands or heads will not shake. The major one that cuts across most healthcare facilities is staff shortage. The staff turnover, because of the Japa syndrome that we are all aware of. Most doctors, nurses, they go for greener pastures, and we have to manage until new staff come in. Since it's a government hospital, not private, it might not be easy to quickly bring in staff to replace those that have exited the hospital. Then, because of this shortage, at times the workload pressure is much on, because even in the isolation center where we work, not all the staff that started with us when it was established in 2020 is available. We have some of them that have gone outside the country. So the workload pressure comes on the staff when there is reduced staff in the hospital. Also, we have some environmental and infrastructural challenges that we expect to be better. Maintenance of some of the materials and facilities is not as we want. Then funding, all healthcare facilities, or most, we still have problems and challenges with adequate funding to have the regular trainings that the staff require. But some of us that have the passion, we go out of our way to do out-of-pocket training regularly. Then the issue of vaccine shortage. I remember the last case of diphtheria we had. I was in a training program and I was telling the NCDC personnel there that we need diphtheria toxin, and they were saying even NCDC is looking for more. And we're only given about 20 or so. And we had 2 cases within that short period. So there's vaccine shortage. Also, hepatitis B vaccine, I think recently, about 2 months ago, there was somebody that needed, it was not available in the hospital. We had to go and source for to be able to give the person a post-exposure prophylaxis. Then concerning meetings, irregular meetings, like I said, the ICC meeting was supposed to be quarterly. Most times we don't do more than 2 in a year. Then irregular training schedule. The training is supposed to be for the staff, existing staff. You know, we talk about training and retraining, even in IPC, but that has not been as often as we wanted. Then the last one I put there is resistance to change. Talking to healthcare workers concerning what they needed to do, and excuses and not wanting to change is also a weakness. That picture is one of the training sessions that we had on IPC. The next one is the hand hygiene 2025 that we did. That it can be, you can have gloves, but it's always hand hygiene is the key. Thank you very much for listening.
So much. Please let's appreciate our Dr. Abimbola with our best emojis. Let's say thank you. Thank you, Dr. Abimbola, for sharing this experience. Actually, I was very excited when I saw that you were working in an isolation center, saying that we're looking at Lassa fever and cholera, whose management involves isolation. So thank you for taking us all the way to Onabisi Olabanjo. Thank you so much for also sharing these experiences. We can see the improvements, and then we can also acknowledge the strengths and the weaknesses. It's a great one. It just shows that there's still room for improvement every other time. So let's appreciate her. Thank you so much. I will go through the chats now to see if we have questions. Let's see if we have questions. I don't know if I'm the only one who is triggered when I hear Lassa fever. Actually, because we have colleagues, health workers who died while trying to save patients, and they have to, get themselves exposed. And most importantly, I can also see here that it's very, very important for patients to present on themselves to the clinics on time. Do we have questions here? Okay, I can see a question. Prof, please, are you still on the call?
I'm readily available.
Oh, that's great. Thank you so much, sir. So there's a question from Dr. Uche. He said sorry. Okay, he said, let me look at the first one. Thanks for this presentation, Prof. We know from evidence the role of multidisciplinary interdisciplinary collaboration and risk.
Risk communication, yeah.
Yes, communication in outbreak management and infection control. In this regard, what lesson do you think we learn in the case of Lassa fever? I think Prof shared some of the lessons. I don't know if he wants you
Okay,
to.
now let me just quickly address that.
Okay.
Thank you for the question. It's more like an observation.
Okay.
And what I want to quote here is that Lassa fever has been there with us for a very long time. If you look at the history, aside that one of the case that was out in Lassa, first epidemic in Nigeria was in 2018. After that, COVID came and pushed it away. After COVID, surveillance increases and people now awareness too. But we still have maybe issues of stigmatization, discrimination. So even the survival have a lot of issues. But what has been successful over the years, which I want to say here now, like my state, Benue State, which is just like every other state as well. This is domiciled in the Department of Public Health of the Ministry of Health. And every state after COVID have now emergency operational center where we have the incident manager that controls every infectious disease, all the state epidemiologists as the case may be. So for the Lassa fever, there's a focal person that coordinates every issues of Lassa fever. And every state, every local government now in my state, the DSNOs have all been trained, they are health educators, they are risk communicators. So once you have any case anywhere suspected, the DSNO will now take the blood, and we collaborate with some vendors. Intranet we're using before, but now other means they take the blood now to the molecular lab where the diagnosis can be done. And in the interim, the patient can now be admitted there in the nearest either primary healthcare facility or comprehensive or secondary healthcare facility as the case may be, before they now transfer back to the isolation theater proper for treatment. So, and in every week, whatever case they have, there's a sit rep. So the Lassa fever focal person gather all the information and send it back to the state where the team now can look at. So aside this leadership role, all the hospitals now, they have been trained, just like the last speaker said, there are IPC team for every hospital, IPC committee. Then this IPC committee have IPC team. There are IPC focal persons in service delivery points so that they can take care of all these things. Then for Lassa fever, once you have all this from the baseline down to the referral level, down to the case now being confirmed, and they are in the teaching hospital or in the isolation center where they are being managed. The management of the patient is not just one person. The resident doctors do rotation. Now, the key or the hallmark here now is that whoever that is seeing the patient who is the trained infectious disease specialist, where there is, and if there's none, anybody who is trained to man this at any point in time. From the continuous monitoring, starting from the physical down to the biochemical and the hematological parameters. Once there's any suspicion or evidence of any organ involvement, then the specialists in that field now will be called upon. They send them referral and they come immediately to come and manage the patient. It is on this note that in the recent time we've been having all our case fatality, all the mortality cases that we have, is either we send them to Irua because of renal involvement and we had no dialysis machine. NCDC had to donate a dialysis machine for us. And in that dialysis machine now, there's a trained nephrologist who is also in the teaching hospital. The nephrologist doesn't get involved immediately. It is when a case now have, a renal involvement that the person now will be called. So by and large, to answer your question, what Lassa fever has done is that it has strengthened the so-called referral system that we know before. It has also strengthened the multidimensional aspect of management of cases that we know before. And it has also strengthened the intersectoral approach of management. And we don't even stop there. There are implementing partners that also assist. When the cases of logistics that is not there, like the last training of the IPC was supported by WHO. And all these things is aimed at effective management of Lassa fever. Because there was a complaint, you have the dialysis machine, they were not trained on IPC, so they will not work. So the WHO now supported us and were able to train those people that they can now work. So as I think to answer your question is more like a contribution per se. Yes, it has helped us. Listening last night that Lassa fever has strengthened our multidimensional approach and intersectoral collaboration in management of endemic diseases or epidemic diseases. Thank you.
Okay, thank you so much, Prof. Thank you for that response. The next question from Dr. Rebi says, Prof, please, can we get protocols of drug treatment for Lassa and cholera? So,
yes, the protocol is available, and all you need to do is to, even if you can Google now, you look at the national guidelines for Lassa fever case management. I think it's about something pages. You can get the PDF and all the protocols there, starting from suspected cases, the probable case, the confirmed, what do you do in terms of this management, and then the IPC component is also there. Then in addition to that, the IPC guideline, the national IPC guideline, also has a section on management of Lassa fever. So if you go to the net now, it is expected that every health facility are supposed to have this domesticated. But if it's not available, you can go there straight away. For the cholera, I'm not too sure. What I've seen is the NCDC protocols and reports, but no guidelines are there. But the complete guideline, I don't have it. But if you go to the primary healthcare manual for treatment, it's also there. So once you get those things, thank you.
all right, thank you so much. We even recently shared one from NCDC on diphtheria to our members. Okay, so the next question is ribavirin really available for use since early administration saves lives? What is the cost effectiveness?
Well, to the best of my knowledge, it's available and it's free. Nobody is buying it. I may not be able to speak of other states, but after the treatment at the stage of the Lassa fever, I have some other colleagues from.
Okay, all right. Thank you so much, Prof. So quickly, there's another one. Prof, why do we still have the same scenario of healthcare workers getting infected even after so many years?
Well, the healthcare workers infection is another issue, and for IPC specialists, they'll tell you that the software of prevention of healthcare worker-associated infection is IPC adherence. Now, why do I have to say that? One of the issues that we have, there are misconceptions concerning IPC. A lot of people will think that until we have a complete PPE, but the most functional evidence-based practices is hand washing. Hand hygiene is key. Either you use hand washing or you use alcohol-based condition. You have to observe the 5 moments of hand hygiene. Once you do these things, you reduce the infection. We have seen that most of the people who are trained as IPC specialists and they attend to their.
Thank you so much, Prof. Thank you for that response. So we have a question for Dr. Abimbola, okay, I can see your hand is raised. Someone is saying to you that, well done, Dr. Abimbola. One key issue you can introduce to your IPC practice is periodic IPC audits. A simple checklist can be used and color-coded outputs. So go ahead, Ma. I can see your hand is raised.
Okay, thank you very much for that contribution. It's well taken, and we also do that. We do under-gene audits. Then the other thing I wanted to add, I was raising up my hand, is concerning the ribavirin is available. Every state have supply of ribavirin. We have presently even in our isolation center. Then concerning the Prof has already enumerated the reason why our healthcare worker are always affected. It's just because many of them think that IPC should be put in place only when they see a labeled case of infectious disease. They are not really trying to accept the fact that every patient we see day by day, we must apply our IPC, standard precaution for every patient. Not until we see somebody bleeding and we think it's Ebola or is any other VHF that will now start putting up IPC. I remember the case that we had that I said Lassa fever last year. The patient came in, and normally when they have such suspicion, they call the IPC team. And I was there and I was telling them, this looks like Lassa. But they kept saying, it cannot be this and this. At the end of the day, the patient came out positive. People that manage, the medical team that managed the case, every one of them started having symptoms. And they had to rush down to the holding area at the isolation center for counseling, for monitoring, and so on. So if all healthcare workers can take every patient as infectious and put up our standard precaution, then the transmission-based precaution as at when needed, every time we see patient, there will be less of this risk. Many of us expose ourselves unduly, thinking it cannot be this, it cannot be that. Thank you.
Thank you so much, Ma. Thank you. Okay, so someone is saying here, okay, Dr. Kennedy says, on the issue of vaccines, especially adults formulation are scarcely available. Okay, scarcely available. In the case of hepatitis B, is pediatric formulation an option for an adult client? That's a question. Prof. Let me repeat, on the issue of vaccines, especially adult formulations are scarcely available. In the case of hepatitis B, is pediatric formulation an option for an adult client? Prof, please, are you still on the call? Prof, are you on the call? Please confirm. Okay, I'm not sure if he's here. Dr. Bimbola, would you want to take the response to that question?
No, ma. Yes, ma. It's 0.5 mils that we give.
Okay.
Yes.
All right. Thank you so much, Ma. So a lot of people are asking if they will get the slides, the presentation. Yes, you're going to get the recorded section. And then someone is saying, I didn't get the document on, we shared via WhatsApp, but I will still reshare again. This is noted. Okay, Dr. Solomon noted, I will reshare with you. I don't know if we still have any other question. Do we have any other question or contribution? Let me scan through. Okay, someone said, during an outbreak previously, vaccinated adults can take the pediatric dose as a boost. Okay, that's a contribution to the question that was that I previously read. Okay, so this is noted. So kindly share the WhatsApp. Okay, okay, I will share with you. Noted. So quickly, I'm going to share the feedback form. We want to get your feedback on today's presentation. And then I also want to let you know that everyone is going to get the slides, the recorded section. Please, let's get your feedback. The feedback form is on the chat box And then for those who might be interested in becoming members, I'm aware that there are people who are joining us for the first time today. Yes, I'm going to share the document. I will, ma. I will. Okay. Those who are joining us for the first time who want to become members of NSIC, I'm going to also share the link on how you can register. And if you have any questions, please reach out to us through our email, nsicnigeria@gmail.com. Please, do we have any more questions or contributions? You have the floor before we draw the curtains. We are almost at the end of today's section. Dr. Shawande, please, are you on the call? Dr. Shawande, are you on the call? Okay, so I've shared the link on how you can register to, if you want to get a copy of, if you want to get the recorded section, if you haven't used this link previously, please do well to share your email, your contact details with us, your email address and your number, so that we can share the recorded section with you. So at this point, I would like to appreciate our speakers. We really, really, really appreciate your time, sharing this experience. Thank you to Prof. Thank you to Dr. Abimbola. We really, really appreciate your time. Any more questions? Dr. Shawande, please, are you on the call? We're about to draw the curtains now. Okay, so thank you to everyone who took out time from their very busy schedule to listen in today. I know that as healthcare workers, we're very, very busy people. But, making out time to be here into this very important section is something that we do really appreciate. And we promise you that we're going to have, this is a monthly echo section. The next section, we have a topic around hospital-associated infections, and we have a speaker ready too, Dr. Fumilola. She's going to be our speaker for next one section. We'll also do well to share the flyers with you as the days goes by. Thank you for taking our time to be here today. Please, we really appreciate your feedback so that we can improve on the program. Please use the feedback form, and also, if you want to get the recorded section, use that link to share your email and also your phone number with us. Please don't drop your email in the chat box. It might not be very easy for us to get everyone's email there. And to ensure that you get the section, use that link to share your details with us. Thank you so much to everyone. And we look forward to having you same time next month. Thank you to our speakers, and do have a lovely evening. Bye.
Bye. Thank you, ma.
Thank you.
Bye. Thank you so very much.
Thank you. And to our speakers, we're going to share our certificates of recognitions with you via email. We really appreciate the time that you have spent with us today. Thank you. And bye, everyone.